Khalida is 230.
सबने ज्वाइन कर दिया।
जी हाँ, मैं ज्वाइन हूँ। सबा ने करना है ना पहले।
अस्सलाम वालेकुम जी।
वालेकुम
वो
अस्सलाम।
कर ले, मैंने
वालेकुम
लिखा है कि
सलाम।
वो कर ले, मैंने कहा है वो कर ले। ओके।
कैसी हैं आप? ठीक ठाक हैं?
अस्सलाम वालेकुम।
वालेकुम अस्सलाम। नजमा
डॉक्टर
कैसी हैं आप?
खालिदा आप
ठीक
म्यूट
ठाक?
है।
जी मैं म्यूट नहीं हूँ।
नहीं आपने डॉक्टर खालिदा म्यूट है।
आ गए।
या यू आर बैक।
So good afternoon, everyone.
Good.
Welcome to today's important webinar titled Congenital Heart Disease in Women, one of the most common inherent disease in women, which affects women across life differently, including unique challenges related with the pregnancy, hormone changes, and aging. This event is organized by the GoRed Pakistan Cardiac Society and African Heart
सॉरी,
Association.
आप सब लोग अपने माइक बंद कर दें।
This webinar helps bring together our discussing the woman aspects of the congenital heart disease, its diagnosis, management, and prevention strategies. So we are having our expert panelist, Professor Masood Sadiq. He is the Vice Chancellor, University of Child Health Sciences and Head and Professor of the Pediatric Cardiology, Children's Hospital, Lahore. Our next expert panelist is Associate Professor Dr. Abdul Sattar Sheikh from NICV. Our third expert is Professor Ambar Ashraf, Coordinator at GoRed for Women, PCS and AHA Pakistan. And she is the coordinator of the KPK chapter of GoRed for Women. Our third panelist is Professor Sultana Habib, Consultant Cardiologist and Postgraduate Training Institute of Kidney Center, Karachi. She is country coordinator of the Rocket trial from ESC. She is the chairperson of ex-professor of cardiology in ICD Karachi. Next slide. Professor Manaz Atik, very well-known peds cardiologist, professor of peds cardiology, Liaquat National Hospital, Karachi. Professor Rajkumar Sajjivani, President-elect, he is President of Pakistan Cardiac Society, Professor and Head of the Department of Cardiology, Ghulam Ahmad Meher Medical College, Qatar. So we are now starting our webinar. Professor Masood Sadiq, Vice Chancellor, University of Child Health and Sciences, Head and Professor of Pediatric Cardiology at the Children's Hospital, Lahore, is with us. I will request him to deliver the opening remarks of this webinar and the objective of this webinar. So, Professor Masood Sadiq, please.
Thank you very much, Professor Soomro, and thank you for asking me to be part of this very important webinar. I think we all know that congenital heart disease is a lifelong condition. And although the prevalence is known to be as 8 per 1,000 live births, we know that there is a regional variation, and we probably have a slightly higher incidence, which is somewhere between 9 to 10 per 1,000 live births. With the considerable improvement in the management of these patients, we know that many of them are now surviving. Almost 90% of children now are surviving into adulthood, and our adult population with congenital heart disease is increasing every day. When it comes to women with congenital heart disease, I think there are very specific issues that needed to be highlighted, and I'm pleased to look at the program that many of these are part of our agenda today. Of course, pregnancy is just one of them. Birth control, menstruation, risks to the fetus, various complications. Which are part of overall adult congenital heart disease, but particularly pertain to reproductive considerations or considerations of pregnancy, delivery planning, and so on. And I think one of the important thing is the transition of care from pediatric to adult congenital heart disease. Um, Obviously, experts will be talking about it, but I think one important context of management of these patients, particularly women with congenital heart disease, is a multidisciplinary approach where we need not only a cardiologist, but we need an obstetrician, we need an anesthesiologist, we need a genetic counselor, and I think all those who are involved in the care of these patients. So I think a very important subject, very pertinent subject to be discussed and deliberated. And I will pass it on to our chairpersons if they have any remarks before we ask the experts to deliver their talks, please. And thank you for your invitation again.
Introductory comments. We are now moving towards our first presentation. Dr. Sabah Dr. Sabhabati. She will.
Can you see my slides? I'm just trying to see if you can see my slides.
Yes, we can.
Okay.
Ma'am, till the time the slides been there, I really appreciate the topic, and it's the need of the day, as Dr. Professor Masood Sadiq have highlighted. We must have to work on it very vigilantly, because the adult population with congenital heart disease, and especially the number of the women, are increasing day by day. I hope Sabah has managed to share the slides.
Can you see my slides now?
No,
Yes.
No?
Not
we can
yet.
see you.
You can see me. Okay, all right. I thought I heard somebody say yes earlier. So
No.
let's try
Earlier
this
you had a
again.
slide put up, but not
Not yet.
it's vanished.
Okay, I'm going to do it again.
Initially, we saw
Okay,
one
do
slide.
you see it now?
Now it's
Yes.
okay. Now it's
Okay,
okay.
all right, great. Thank you, everyone, Dr. Khalida, for arranging this very important webinar and for inviting me to talk on this really important topic. I have been asked to give this once before. I believe it was not last year, but in 2022, because I remember giving it in the car when I was going between Sakkar and Larkana, and I had to do this without slides. And so what I've tried to do today is actually include a few cases and put in a few images. As you all know, 10 minutes is really not enough to cover much, and I'd like to try to stay on time, so we'll see what we can do here. But in generally, there've been a lot of advances. In general, there've been a lot of advances in cardiac imaging, and we don't really dichotomize it in terms of men or women, but the important considerations obviously are going to come in when we think about childbearing age women, and we talk about ionizing radiation studies like cardiac CT. So I will specifically comment on those things, but the overall concepts of when to use it and what type of study to use for what type of congenital disease is what I'm going to focus on. Okay. So can you see my next slide here? It's a central illustration.
Yes.
Okay, great, because I had a problem advancing it. So this actually just recently got published in the Journal of American College of Cardiology, and it's their central illustration that really talks about the innovations in cardiac imaging and the paradigm of how to use this. As many of the experts here are aware that most of us work at institutions that have multimodality imaging. So often the question becomes, what to use, when to use. And then, of course, we have, a specific challenge where we are working in an LMIC, a low middle income with limited resources, and trying our best not to put a burden on the patient. Most of the patients are not insured. So unless they're getting their imaging at a center where things are free of cost or extremely subsidized, it's a huge cost burden. Really, even in the West, most of the evaluations are going to start off with a 2D or a 3D echo. You can see here in echocardiography, the most important things are that, valve morphology can be studied, septal defects can be easily identified, outflow tract obstructions and velocities, pressure gradients can be measured. And I really feel that even with all the modalities and with the ability to detect stenosis even on cardiac MRI, my go-to for valve diseases and LVOT obstruction is still echocardiography, just plain simple 2D echocardiography. And then, now with the newer advances, we have the ultra-fast ultrasound. We're able to use AI and techniques to quickly give us ejection fraction at the touch of a button. In countries that have perfusion imaging with things like Definity, which is a type of an echo contrast agent, which has inert gases attached to a bubble. Those can help look at wall motion abnormalities and perfusion. So we don't have that yet in Pakistan, but that's another one of the advances. And then, of course, 3D echocardiography is really made valvular heart disease so much easier to understand in terms of being able to lay out the surgeon's view for the surgeon, but also really to define and look at exactly where those leaflet perforations are or the atrial defects are. And we used to think of about 10 years ago as 3D echo as something optional on TE or something that's just a toy that's fancy. But now most of our valve cases, if not all of them, we try to get 3D imaging on them so that we can guide our surgeons better and show them a view that actually is going to look like the view when they open up the patient. The next thing listed over here, interestingly, is cardiac MR. I think most centers have cardiac CT, and usually we think of that as something in addition to cardiac catheterization, where pressure gradients can be measured as being more accessible. But in the West, really after echocardiography, these patients do get cardiac MRI. Now, cardiac MRI is something that is absolutely, extremely important in congenital heart disease patients. It can give us everything that we get on echo, and then so much more in addition to that. The biggest strength of cardiac MRI is its spatial resolution. So everything that we see on echo is visualized, but is visualized at even higher quality. But in addition to that, tissue characterization. So being able to tell using certain protocols if something is fat or if it's scar, if it's tissue edema. So we just started our cardiac MRI program at NICVD this year in May, and we are doing tissue mapping. So we do T1, T2 mapping, and we're able to tell if something is tissue edema versus scar. And that has been extremely helpful, in addition to being able to look at the anatomy and the physiology and trying to do the flow assessment. Cardiac CT, as I mentioned earlier, again, there are many patient-specific protocols. You can try to optimize the radiation dose. The biggest problem here, obviously, is radiation, but there's a way to shield the patient. And for the most part, I am going to talk a minute here about if a patient is pregnant, really, we should be avoiding any tests if they're not going to change management. And even for MRI, the gadolinium contrast is not recommended during pregnancy. And in fact, if a patient really needs to get a cardiac MRI, it should be done in the second or third trimester because there are no safety studies in the first trimester. And so for the most part, I try to convince the teams that are asking us to do a cardiac MR or cardiac CT in a pregnant patient that if it's not going to change your management, then please try to avoid doing it. Cardiac catheterization, I don't think I need to say much more about that. And then there's the advanced digital technologies. And so, there's the digital twins and trying to create 3D models of, things. And many of these don't apply to us right now because we are, again, trying to even provide the basics to our patients. So again, I touched on this and I'm going to move through it quickly, but the first line modality for most of our patients, adults or children, is going to be echocardiography, a good 2D transthoracic echocardiogram. And then after that, the choice of further imaging will really depend on the clinical questions that remain to be addressed. The strengths of the MRI, again, as we said, it is a comprehensive access and coverage of all parts of the right ventricle, which is sometimes difficult to see on transthoracic echo. The pulmonary artery, the pulmonary veins, and aorta are well visualized. And then we're able to also do the tissue mapping and also give contrast and look for enhancement, being able to tell if there's scar or not. And I think one of the biggest roles of it comes in the tetralogy of Fallot patients, where we need accurate estimations of the indexed diastolic volumes, or we need the RV ejection fraction, or we have a severe pulmonic regurgitation case, which on echo, is being called as moderate to severe by someone and severe by someone else. And now we really need that really accurate regurgitation fraction. And so these are the patients, I think, that benefit from a cardiac MRI in our setting. The cardiac CT strengths really are the spatial resolution and the rapid acquisition. So again, even with the fastest protocols that we use for a cardiac MRI, it takes us at least 30 minutes at the moment. But we used to do protocols, even in the West, that take almost up to an hour. So asking somebody to breath hold, sometimes it's uncomfortable for the patient. The cardiac CT is faster, and we're able to get a lot of information here. One of the things that on the previous slide that I should have mentioned is these days, if a patient has an MRI, they're often, if not always, MRI compatible. But that is always something to check on. If they have metal, because often these patients have had surgical techniques, we need a detailed surgical history of what they've had. So essentially, this is something that on CT we don't have to worry about as much. We get a lot of artifacts from the metal in there, but we can at least do it quickly and not worry that the MRI, the pacemaker, is MRI compatible or not, and things like that. But of course, the radiation is a concern in a younger patient, especially if the patient needs a follow-up every year or every 2 years, if the aorta is being followed up for dilation, if they're getting really close to the cutoff for surgery, then this becomes a concern, and MRI might be a better test. And then adults with relatively complex condition really should be managed at a specialist adult congenital heart center. I think most of the experts here would agree on this, that, even with echocardiography, there's such a variation in the type of reports we get back when we order them. And we see these reports coming from different hospitals from all over the city, really where the expertise is not there. And I think that gets amplified as you move forward to cardiac CT or cardiac MR. If they are performed or read at centers that do not have the expertise, you can really get a confusing report and then really not know what to do with the patient. So again, 10 minutes is 10 minutes. So I'd be happy to, give a different talk on a different day. But I just wanted to show you some cases, some examples that we've had. So this is a 19-year-old female, actually from Afghanistan, who was referred to our valve clinic for aortic valve replacement for what they thought to be simple aortic stenosis. And so, we found this on her physical exam. Even our surgeons had not mentioned it, but, her feet look like this. And honestly, it was so soon after I had moved from the US, and I was telling my fellows, oh my gosh, I've never seen anything like that. I'm sure all of you have, because now I've already seen a few like this. But, her LDL did come out to be 720. And she did have familial hyperlipidemia, which she had no idea about. And then on her echo, she did have an area of narrowing in her LV outflow tract. When we saw it was a small annulus, but her valve looked like it was, opening, but there was some degree of stenosis, but it was not like as stenosed as we initially received on the report. Although her gradients did measure in the 40 to 50 range, so it was, significant in terms of stenosis. So she also had a little bit of aortic regurgitation. Her mean gradients across the aortic valve were a mean of 45. So I'm showing you these cases just to show you that these are the sort of the images that you want to see in terms of 2D color, spectral Doppler. There should be, clean images with measurements of PA pressures. We proceeded on a TE with her, and on TE again, she was noted to have a bicuspid valve with doming, narrowed annulus, and then in the supravalvular area, she also had a narrowing and a ridge. And as we proceeded forward in her workup, we also performed a cardiac CT because that's our protocol with bicuspid valves to see what was going on with her aorta. And on her cardiac CT, we actually found that in addition to that, she also had left main disease. So at the age of 19 now, you have left main disease, aortic valve disease, supravalvular narrowing, a narrow LVOT tract. Here's her 3D echo imaging. And again, you can see that stenosis with the supravalvular ridge, her CT that showed left main calcification, as well as confirmed a small annular size. So she ended up undergoing surgery. She had a lima to her LAD. She had an aortic valve replacement. She also had resection of that supravalvular ridge and expansion of her LVOT. A really complex surgery, and actually walked out of the hospital feeling much better. Her initial symptoms were dyspnea. So case 2 is a 17-year-old female with tetralogy who had a total correction. She'd been having dyspnea for about 6 months. Now she had some echoes that moderate to severe pulmonary regurgitation. We can debate them when I show them to you. But essentially, she's a patient that we ended up thinking would be a good candidate for cardiac MRI, just to kind of assess exactly her degree of regurgitation, but also what her MR volumes were, her right ventricular volumes were. So again, to me, it does look like she has significant pulmonary regurgitation, but she had multiple. Some of your patients, I'm sure, shop around like ours. They'll go to NMC and 2 other labs before they come to us. And so, you have reports with moderate to severe, severe. So here are her MRI images performed in our lab, and you can see the RV is dilated. So we usually perform the measurements and we index them. And then we measure the regurgitant fractions, and hers was found to be severe pulmonary regurgitation with the dilated right ventricle, and RV ejection fractions can also be measured. This case is a 43-year-old female with tetralogy, again, correction done in 2005. And again, her transthoracic echo was, read as dilated RV with dysfunction, with moderate to severe PR. And so on her MRI, we were able to assess that her right ventricular end diastolic volume index was 168. And she actually had normal RV function, because on echo, a lot of times people will read it as dilated RV dysfunction, but there's not always RV dysfunction when there's RV dilation. So regardless, we provide all that information, including the late gadolinium enhancement information and the pulmonic valve annulus. And here are the images of this second patient that I was just telling you about. I think even on echo, you can see the dilation, but you just see it so much better on MRI. These are the patient's MRI images. We can see that the RV is dilated. And again, we're able to provide you measurements and all the information that you need then to make your decision about whether you want to manage the patient, or whether you want to manage them surgically or not. So it looks like we're out of time. I had a case of an anomalous coronary case that was managed using cardiac CT and many other cases, but we'll save those for another time. Thank you.
Thank you.
For your comprehensive presentation on the imaging techniques for congenital heart diseases. Let us now hear from our other chairpersons. If there anybody to comment on her presentation from the chairpersons.
Yes, wonderful presentation, Sabha. And obviously, the role of MRI is, you cannot undermine that. But in our setup, accessibility to MRI is little less. Not every hospital or every institution offers that. And the private institutions, that's very, very expensive. So that is a little, and then from that point of view, then CT scan becomes a little, CT angiography becomes a little more affordable and practical in some sense. And pre-operative information, a lot of times in pediatrics, is quite adequately furnished by the CT angiography. So, going for an MRI is usually we reserve it for complex cases, and probably the post TOF repair, PVR are required. He said that, I mean, you have CT scan, it's probably more accessible. So that, I mean, we would love to have MRI everywhere in the country, but
Yeah, no,
that's our limitation.
I agree with you. I believe it's about 95,000, you know, at AKU, and cardiomyopathies. There's a lot of cardiomyopathies that are underdiagnosed, like sarcoidosis, amyloidosis, AVC, and you know, we know that there's so much more need in the congenital arena. But with Dr. Sattar, we've started recently doing more thalassemias. We're doing more tetralogies because we did promise him that we would start doing congenital MRIs as soon as we can. And so there's a big need, and I completely agree with you. I think in our setting, try to get as much information from echo, CT, and cath, and reserve MRI really for patients that it's going to add additional information.
So I will like to ask the question from Professor Dr. Sattar Sheikh. They have established units all over the center, and they must be dealing with these ladies over there also. So we cannot expect that there will be MI or other advanced modality for the diagnostic purpose. So how they are managing and they consider most effective diagnostic modalities over there. Is there any arrangement in peripheral areas for this in this field?
Assalamualaikum, madam. Yes, madam, we the properly compiled system for the imaging. Everywhere in the major centers, there are the imaging consultant present, mostly like at the Sakha Center. There is a CT scan and imaging, all modalities are present except the cardiac MRI. But these imaging persons are mostly working in coordination with the Karachi, and they are recording all the data on the PECs, including CT scan. So we can discuss all cases, like for example, any complex case, most likely the other congenital case, we are discussing with each other. And, for example, Dr. Sabha is also remain on loop. So any case which is multidisciplinary, we are involving the all stakeholder, including the surgeon and our imaging person, Dr. Sabha, CT scan person, or interventional cardiologist, adult cardiologist also, to take the proper decision for the any adult congenital heart disease, whether is operated. So if a patient needs the multimodalities, then we are mostly referring these patients to the Karachi Center and doing the cardiac MRI or other advanced cath or intervention. And I think most of the patients already shifted to Karachi for the MRI, but there's a high volume, and we started recently within 6 months, 300 cases of cardiac MR done. But if we cannot precisely break through and make some proper cutoff line for these patients, and according to guidelines, then there will be a huge volume. That's why we are referring the case according to guidelines. Which modality is more beneficial, whether CT scan, thallium, MRI, or cardiac catheterization, or some direct case with intervention. So it's not difficult nowadays because all things are on the PECs, and we are sharing the data with each other and taking the final decision for the benefit of patient.
What about the awareness level of the women of the peripheral areas about their congenital heart diseases? This is
Yes, madam. The woman belongs to the interior and initially at the we can say like 8 to 10 years back, it was we can say very less because there was no properly established center. Only few centers like at the Ladkana, Sakhar, Hyderabad, few consultants were present that know how to deal the congenital heart disease, and they were referring the patient mostly to Karachi. Like in 2015, only the one major center in the Karachi government center in ICVD that were taking care of all the interior scene and one private center, Aga Khan. So after that, once we develop the network and develop the centers at the Larkana, Sakhar, Khairpur, Hyderabad, Okhan, Seven, Mithi, then we started the public awareness with the help of a general physician, pediatrician, and specialist, especially gynecologist. We started the how to take care of the mothers who is a known case of congenital heart disease, or the mothers who has the baby with congenital heart disease, how to scan the fetus who is suspected with congenital heart disease according to predisposing risk factors. And after that, we are enrolling these patients with the help of local GPs and pediatrician and gynecologist, these mothers. And they are coming to the at our major centers like Sakhar, Larkana, Hyderabad, Tamukhan, and we are enrolling them. Then, for example, they are pregnant, and then we are scanning the fetus, fetal echo, and also identifying what are the risk factors, any congenital heart disease within the fetus or not. They also counseling the family regarding the pre-conceptual conceptual how to take care of the baby, how to make a good nutrition, weight, vaccination, prevent the other risk factors, and where they can go for the delivery if patient is having the significant congenital heart disease. And also we are doing the cardio ops clinics at the Karachi with the help of Dr. Sabah and Dr. Hana at Civil Hospital, Jinnah Hospital, and NICVD. So regular cardio ops clinic for the screening, for proper treatment, and for properly delivery, and after delivery, we are taking care of these babies. So with progression of time, there's a significant improvement in the awareness as compared to 10 years back to now.
Thank you so much, Dr. We are now, any question from the other
Can I ask a
persons?
question?
Are already getting late.
Can I ask a question?
Yes, Sultana,
My
you
question
can.
to Sabah
It
is
will be now.
my question to Sabah is, since we are talking, we are discussing on congenital heart disease. I want to highlight the use of 3D, which she has not done it in, especially it will be very feasible and very informative for patients with congenital heart disease. Use of 3D. Can you highlight what you have been doing to improve or increasing the use of 3D along with 2D so that other expensive and major imaging testing can be avoided as far as possible?
Sure.
Yes.
Dr. Sultana, I did mention it when I showed the first slide, the central illustration that given the 10 minutes, it's hard to go into details of every modality, but 3D is
No, how
extremely
you
important.
have done improvement? Like,
Yes.
have you projected use of 3D in patient with congenital heart disease? Because 3D plays a very important role in defining the structures, hemodynamics, and everything, especially in complex congenital heart disease. For the diagnosis, I'm asking you.
Yes, but when you say 3D, that's general, right? So it's this 3D echo, there's 3D transesophageal echo, then there's 3D reconstructions of cardiac CT. I'm assuming you're talking about 3D echo. So on 3D echo, basically what we do is we always start with a good 2D echo. When we've been training our staff, we have limited number of machines that have 3D echo. We have 2 machines with 3D echo. We try to do a 3D TE on all patients that are going to have any kind of valvular or like a septal defect or anything like that that might help guide make that decision if it's going to be able to be done in the cath lab or if it needs to be done surgically. So that's one example of a scenario where we have performed 3D imaging of an atrial septal defect, defined all the the septa to see if there's enough gap and there's enough rims on all sides. So then we've closed it in the cath lab as opposed to closing it surgically. That's one example. But for valve disease, We use it very commonly. Almost all our patients get a 3D TE. Now, as far as cardiac CT goes, all our patients get a 3D reconstruction of their aorta or anything else we're looking at. It's just part of the study. So yeah, we can talk more about this offline. I think Dr. Khalida wants us to move on.
Yes. So thank you, Dr. Sabhabati, for your excellent presentation and the interactive discussion from the panel of experts. We are now moving towards the next presentation by Dr. Najma Patel on hormonal fluctuations, heart health, congenital heart disease across the female lifespan. This Dr. Najma, have you uploaded your
मेरी
slide?
हाँ ठीक है. Can you see my screen?
Yes.
Okay.
No.
No?
No. It's gone now.
Have you allowed me to share? मेरा ख्याल है मेरी स्क्रीन होनी चाहिए. मेरे पास तो आ रहा है allowed. क्या?
नहीं आ रही।
We can see you. I mean, I am seeing you.
इसमें ये आ रहा है कि allowed allow करें मुझे screen sharing.
हाँ? नहीं डॉक्टर नजमा की प्रेजेंटेशन को अलाउ करो.
नहीं ये लोग कर सकते हैं. पहले मैंने इनको एक्सेस दिया था सर.
मैंने
अभी मैं
हाँ
बताऊं
दिया
क्या?
तो मैं हो क्यों नहीं रही है. अच्छा एक मिनट.
क्या है आप करो.
हाँ मैं देख ही रही हूँ वो. But I don't know why it's not go can't do it.
क्या प्रॉब्लम हो रही है नजमा?
हाँ यही मुझे समझ नहीं आ रहा प्रॉब्लम क्या हो रही है. ये शेयरिंग में आके कहाँ जा करना है मुझे. होस्ट टूल्स और
डेस्कटॉप में.
डेस्कटॉप पे तो मैं हूँ.
हाँ
शेयरिंग पे क्लिक करके डेस्कटॉप पे क्लिक करिए.
आप बोल दो ना. बोलो.
वालेकुम मैम. आप शेयर पे क्लिक करके डेस्कटॉप पे क्लिक.
नजमा आपको होस्ट ने अलाउ किया हुआ है. ये ना होस्ट ने अलाउ नहीं किया
जी
हुआ.
ऑलरेडी होस्ट किया हुआ.
अच्छा.
थोड़ी देर पहले स्क्रीन आ रही थी. We could see your screen short while ago.
करो.
डॉक्टर पटेल आपकी स्लाइड्स नहीं नजर आ रही. मेरा ख्याल है यू हैव टू गो बैक टू योर स्लाइड शेयर और वो करें और कोशिश करें या अगर पहले उसको ऑफ करके दोबारा ऑन कर लें.
आप बोले
आ गई है आपकी प्रेजेंटेशन.
अब आ रही है
उस पे लेके
और
जाओ.
इसको अब आप फुल स्क्रीन पे ले जाओ.
Just a minute.
देख सकते हैं.
महाजन बताओ.
ओके.
Can you share? See?
परफेक्ट.
Okay.
ये कैसे हो पाता है?
ये फ्रीज क्यों हो गया.
Yes.
ये फिर गायब हो गई ये लग रहा है.
नहीं हम देख सकते हैं आपकी.
आपको क्या
स्लाइड
नजर आ रहा
आपकी
है?
नजर आ रही है लेकिन पूरी नजर नहीं आ रही. आप पहले
स्लाइड शेयर पे आना पड़ेगा क्योंकि दोनों आ रहे हैं. आप भी आ रही हैं आपकी प्रेजेंटेशन भी आ रही है.
हाँ.
मैं स्लाइड
पहले
शेयर
आप
स्लाइड शेयर पे आए और दूसरा
आपने
उसको.
connect किया था.
मैंने यही किया था लेकिन वो बीच में पता नहीं क्या हुआ. एक मिनट.
अभी भी आप दोनों आ रहे हैं ना डॉक्टर नजमा. आप भी आ रही हैं और आपकी स्लाइड्स भी आ रही हैं. आपकी सिर्फ
तो मैं
स्लाइड्स आनी चाहिए.
हाँ अब क्या आ रहा है. मैं भी आ रही हूँ.
दोनों आ रहे हैं.
मैम एक काम करें आप फिर से स्लाइड
मैं
शेयर
इधर
करें.
से कर सकती हूँ. ओके एक
फिर से
मिनट.
स्लाइड शेयर करें.
कर दी ना.
एक दफा ऑफ करके शेयर करें.
हाँ एक
मैम
मिनट.
फिर से
मैं
आउट होके
इसको
वापस इन.
एक मिनट इसको व्यू इसको खत्म कर लूं.
आई थिंक द होल स्क्रीन इज शेयरिंग.
नहीं ये स्क्रीन इसको खत्म व्यू को खत्म कर दूं मैं. नहीं, लेकिन तो सेल्फ व्यू गया। ओके, नो, ये कुछ और हो गया। शेयर पे ही गई थी ना। I don't know।
नीचे आपके एक आइकॉन होगा
अब आ
स्लाइड
गया,
शेयर वाला,
अब आ गई, अब आ गया।
उसको आप क्लिक करें।
Ma'am, same problem. Now better.
नहीं
Yes.
नहीं, दोनों आप आ
अब
रहे,
आ
अब
गया।
आ रही,
आ गई,
अब आ रही है।
आ गई, आ गई। चले, दोनों ही आ जाने दे। अच्छा, अब क्या हो रहा है? अब मुझे, मेरे पास कुछ भी नहीं आ रहा।
दोनों ना
अभी आ
आने दे,
गया, आ
एक
गया।
आने दे।
मैम आपकी स्लाइड शुरू
आई
हो गई।
कांट सी दिस, मुझे नजर नहीं आ
इसलिए
रहा। आप
इसलिए
अपनी
मैंने बोला था कि मुझे भेजो।
मैं भी
आप
भेज देती
कंटिन्यू
हूँ।
करें, आप कंटिन्यू करें, नजर आ रहा हमें।
We
मुझे
can see
मुझे
the
आप
your
लोगों की
slides.
शक्लें नजर आ रही हैं।
Slides नजर आ रही हैं। मेरा
हाँ
पहले
वहां
शुरू
इसको
कर।
हाइप करो ना पूरा।
कंटिन्यू करें ना नाजमा, वी कैन सी योर स्लाइड्स।
मैं, आई कांट सी माय स्लाइड्स।
अस्सलाम वालेकुम
You can
मैम।
go at
मैम
screen
आप,
4.
मैम आप इसे सारा शट
एक
डाउन
मिनट,
करें।
मैं दोबारा से कर रही हूँ। मैं
शट
इसको
डाउन
मेरा
करें
पहले
तब होगा, अदरवाइज आपकी लैपटॉप पे स्क्रीन ब्लैक रहेगी। वो आपने डबल शेयरिंग नहीं की, वहाँ F2 का बटन दबाएंगी।
ये जो है ना, गैलरी वो खत्म कर दो। और शेयर, अब हो रहा है शेयर?
Yes.
यस
Yes.
हो रहा
मैम।
है, हो रहा है, हमारे पास हो रहा है।
हो रहा है तो कैन आई
Yes,
स्टार्ट?
हाँ
मैं आई स्टार्ट ना?
हाँ, यस यू कैन।
ओके, मगर मेरे पास इशू ये आ रहा है कि मैं स्लाइड मूव नहीं कर पा रही। ओके,
हाँ
every time it's going on the opposite direction. I don't know what is happening. No, मैं इसको इसी तरह से कर देती हूँ। ये वाला चीज आ रही नजर?
हाँ, अब आ रही है।
जी मैम, इसी तरह करें कि आपके
स्लाइड
सिस्टम में
शेयर।
प्रॉब्लम फुल नहीं होगा,
हाँ
इसी तरह चलें।
मगर ये नहीं, हाँ अब हुआ। ओके,
इसी तरह कर दो, इसी तरह कर दो।
हाँ मैं इसको इसी तरह कर रही हूँ। ओके, topic is women hormonal fluctuations and heart health, congenital heart disease across the female lifespan. Women with congenital heart disease may experience hormonal changes and gynecological health issues at various stages of life, including menstrual irregularities, contraception, pregnancy, subfertility, and menopause. Menstrual irregularities, menstrual disorders are more common in women with congenital heart disease compared to women without congenital heart disease, and are associated with presence of cyanosis, the number of surgical interventions, and the severity of congenital heart disease. The prevalence of menstrual disturbance may vary according to the patient's cardiac status. There is higher prevalence of menstrual disturbance in women with complex as compared to with those with simple, and more in cyanotic heart disease, especially after Fontaine operation. Menstrual disorders include delayed menarche, amenorrhea, dysmenorrhea, frequent menstrual bleedings, or irregular menstruation. In this study, it shows that only 32% of the female had normal menstrual cycles. Menstrual cycle disorders are caused by hypothalamic pituitary dysfunction, ovarian insufficiency, and other conditions such as polycystic ovary syndrome, reduced estrogen resulting from premature ovarian insufficiency, or hypothalamic pituitary failure results in osteoporosis and vascular deterioration. Statistically significant difference in anti-Mullerian hormone was found when comparing women with Fontaine circulation and healthy controls. There were no statistically significant difference between women with other complex congenital heart disease conditions and control women. Decreased ovarian functions occurring prior to menopause leads to cardiovascular deterioration. Estrogen replacement therapy with early initiation for women with premature ovarian insufficiency is recommended at least until the average age of natural menopause in order to control and prevent cardiovascular disease. Reproductive health of women with congenital heart disease. First of all, we'll discuss the contraception. Safety concerns differed by contraceptive method and congenital heart disease type. Combined hormonal contraceptives which contain estrogen plus progesterone may increase women's at risk of arterial and venous thrombosis, may be highest in women already at high risk of thrombosis as in cyanosis, Fontaine physiology, mechanical valves, prior thrombotic event, and pulmonary arterial hypertension. Fluid retention, interaction with cardiovascular medications, interaction between oral contraceptives and cardio medications possibly result in reduced effectiveness of either drug. Cardiac medications such as busulfan or warfarin may interact with hormonal contraceptives, decreasing the effectiveness of either or both medications. Progesterone-only methods are generally considered safe for women with risk factor for thromboembolism. There are theoretically concerns with insertion of intrauterine device such as arrhythmia, vasovagal response, or infection leading to endocarditis. When they are inserting it, there are pain and many other factors which females who already have compromised hemodynamics cannot tolerate this. Then pregnancy. Major changes in hemodynamic, hormones, catecholamine, autoimmune nervous system, and psychological condition during pregnancy and delivery. Specific coexisting hemodynamics of congenital heart disease, surgical scars, genetic abnormalities, underlying cardiac failure, ethmogenicity, all these contribute to outcome of pregnancy in women with heart disease. Effect of hemodynamic changes during pregnancy on cardiac status. There is increased blood volume, cardiac output, and heart rate. Vascular resistance decreased by 40 to 50%. Oxygen consumption increased by 15 to 30%. These changes result in increased right to left shunt as vascular resistance decreases, increase in gradient across stenotic lesions, congestive cardiac failure, and these all may result in maternal or fetal deterioration in women with congenital heart defects. What lead to this? There are various changes which I have already discussed this. Physiological changes, hematological, hypercoagulable state and anemia, respiratory changes, increased tidal volume, aortic valve fragmentation of medial elastic fiber, autonomic nervous system increase heart rate by 20%, hormonal increase, control like cortisol, estrogen, and RAAS system, reticuloangiotensin-aldosterone system. Increase and volume and cardiac output and decreased vascular resistance results due to increase as a consequence of renal sodium absorption and water retention, which results from increased aldosterone production via the renin-angiotensin system as a consequence of placental estrogen production. And the uteroplacental circulation acts as a low resistance circulate with increased blood volume and cardiac output. Hematological changes during pregnancy, the procoagulant activity increases, manifested by elevation in factor 7, 8, 10, fibrinogen levels, and Wilbrand factor, while the anticoagulant activity decreases, characterized by reduction in fibrinolysin and protein S activity, resulting in hypercoagulation. That increases risk of thromboembolism. Then respiratory changes are result of the increased progesterone levels. This results in hyperventilation, residual volume in decrease by 40%, increase in tidal volume. Later in pregnancy, lung volume results decrease due to elevation of diaphragm. Great arterial wall. Increased production of estrogen results in increased fragility of arterial wall. Relaxin in the serum during pregnancy causes a decrease in collagen synthesis, causing fragmentation of medial elastic fiber in the aorta that increases aortic diameter and stiffness. This is adaptive response for increased blood volume to placenta. Since aortic valve becomes fragile during pregnancy, aortic dissection may occur in susceptible patients such as Marfan syndrome associated with dilated aorta. Subfertility and infertility. Up to 15 to 18% of couples in the developed world experience subfertility and infertility. This is overall. Women with congenital heart disease have lower birth rate as compared to control, irrespective of severity. In congenital heart disease patients, as there is high incidence of ovarian insufficiency, this may be the reason, specifically after Fontaine operation in cyanotic heart patients. Assisted reproductive technology can be offered, but have risk. The occurrence of complications during ART in women with heart disease varies from 3 to 18%. Any treatment which give higher chances of multiple pregnancies should be avoided because the hemodynamic disturbance becomes double of the single pregnancy. Assisted reproductive technology is indicated in women with modified WHO class 4, and that caution is advised in women with modified WHO class 3 or those who are anticoagulated. ART may be complicated by, for example, bleeding, thromboembolic events, or anesthetic-related risk resulting in acute and or major hemodynamic shifts and ovarian hyperstimulation syndrome. This is in all persons receiving this treatment. However, there is increased risk of outcomes, adverse outcome in pregnancies conceived with ART in women with congenital heart disease due to these complications. As these hemodynamic shifts and the risk can lead to life-threatening situation as they may be less capable to adapt due to compromised cardiac function. Any menopause कहाँ गया भाई? Women with congenital heart disease have slightly higher risk of early menopause. The principal goal of HRT has been delivered to lowest effective dose of estrogen and progestin to relieve menopausal symptoms and to potentially reduce the risk of coronary artery disease and osteoporosis. However, now there are questions for this to use in even in healthy women because of the increased chances of breast cancer and the effectiveness in reducing the coronary artery disease. Thank you. मेरा ख्याल है मैंने ज़्यादा जल्दी खत्म कर लिया. Thank you.
Thank you, Dr. Najma, for excellent presentation on this important subject. I have really first time heard about the whole subject with interest. So let us now open the discussion with questions from the participants and from the chairpersons. Any question from the chairperson?
Can I ask?
Before you ask from a question, I will ask from you, Dr. Sultana Habib. How can a clinician, general practitioner and clinician can better anticipate and manage hormonal fluctuations in women with congenital heart diseases, particularly during the pregnancy and menopause? Simple method.
Can I ask Najma a question?
No, I want to ask from you, please. As a chairperson, from you, your comments on this question.
I don't know. Can you repeat it, the question?
How can a clinician or general practitioner can manage hormone indications and a simple sign which a clinician or a general practitioner can assess?
Why don't you put this question for a gynecologist?
they have this topic in hand. They might ask you first. Maybe we can discuss this in the next topic, which the gynecologist has, and they have the same. They will have to. They will answer your question. So why don't you ask
May I
them
answer
when they
this?
will deliver the lecture?
Okay.
May I
May I
ask
answer
Najma a
this?
question?
Najma,
Yeah.
if Najma can answer this question.
मैं इसको देखें, ये मल्टीडिसिप्लिनरी चीज है. हार्मोनल ट्रीटमेंट is the job of gynecologist, but what should be given and what can be what cannot be given, the adult congenital heart disease specialist can guide them.
नहीं,
जी डॉक्टर
इसमें तो ना
सुल्ताना.
गायनेकोलॉजिस्ट का पार्ट ज्यादा इम्पोर्टेंट होगा नजमा. कंजेंटल हार्ट डिजीज एंड इनफर्टिलिटी है, उसको कॉन्ट्रासेप्शन देना है या उसको बर्थ
वो
के लिए
दोनों
प्रेगनेंसी
कंबाइंड होता
लेने
है
के,
ना, दोनों कंबाइंड
हार्मोनल
होता है. हम उसको ये
रिकमेंडेशन
गाइड
will
हम
be made by
हम
the gynecologist, I think.
हम
Why
उसको
don't
गाइड
the
ये करते हैं.
gynecologist
सॉरी,
answer that?
हम उसको ये गाइड करते हैं कि ये चीज नहीं देनी है, ये चीज देनी है. वो हमसे पूछते भी हैं, और समटाइम्स अगर पेशेंट डायरेक्टली आते हैं तो हम उसको कहते हैं कि उसको ये चीज नहीं देनी और ये चीज
तो ये
देनी है.
गायनेकोलॉजिस्ट को बताना है पेशेंट को.
दो
दिस
आइदर
इज
वे
द
होता है, कभी
गाइडलाइन.
गायनाकोलॉजिस्ट पूछता है हमसे.
Can I just make a little comment? इसमें the
Yes,
basic
Dr. Shabal, yes, okay.
See, I think what it is now is this is cardio obstetrics now, and it will be an adult congenital heart disease and obstetrics. So I think this is important that it is, as Dr. Patel said, this is a multidisciplinary approach that we have to have. The gynecologist, the child specialist, the adult congenital heart disease specialist, because now we have patients with adult congenital heart disease who have now reached that stage.
Yes,
They
I think
are
it's
getting the women like it. Management now is going to be different. It's a multidisciplinary management that we have to have.
Thank you. Thank you for
डॉक्टर सुल्ताना आपका क्वेश्चन. डॉक्टर सुल्ताना आपका क्वेश्चन.
नजमा, क्वेश्चन ये था कि व्हाट इज द रीजन फॉर menstrual disorders or infertility in women with congenital heart. रीजन क्या है उसका? उनको
इसका रीजन यही
एडिमिनोपॉज हो
वो
जाता
बताया
है
था कि
उनको.
डिक्रीज ओवेरियन फंक्शन होता है, हाइपोथैलेमिक पिट्यूटरी फंक्शन डिक्रीज होता है. यूजुअली
But
एक जो सिंपल कंजेनाइट
why it
बात कर,
happens?
सिंपल कंजेनाइटल हार्ट डिजीज में इतना डिफरेंस नहीं है, लेकिन जो साइनोटिक है, कॉन्टैन है, कॉम्प्लेक्स सर्जरीज है, उसमें ज्यादा है बिकॉज ऑफ द inability to increase the cardiac output or the hormones, anti-Mullerian hormones, depression, all these things leads to this.
मैम ये gynecologist की
Thank you.
presentation में है. First listen the presentation of gynecologist and then clear all concepts.
Basically, the whole
This is
system
what I
changes.
was trying to tell Khalida. Let the
The whole
gynecologist has to
So
deliver their
we are
lecture and
getting
we
late,
can
so
ask
I
this
will
question.
try to move for
ये
our
जो
third
congenital heart
presentation.
disease की patients होती है ना, इनका पूरा system बदला हुआ होता है. They are not like normal women. So that is why there are changes in the ovarian response also, or menstrual irregularities and menopausal irregularity. ये सारी चीजें because of the change in their system. That is what it, and I think it is absolutely right कि जब operation हुआ हो, fontan वगैरह हुआ हो, तो उसके अंदर definitely changes और भी आ जाए.
अच्छा, may I ask you, thyroid
So,
gland, how it plays the role, because it is responsible for metabolism. So thyroid should be looked into as well. The thyroid hormones and PCS effects.
so now we are moving towards our third speaker, Dr. Shabnam Nas. She will speak on reproductive challenges and fertility consideration for the women living with congenital heart disease. She is
Assalamualaikum.
the leading
Am I audible to
cardiologist.
you?
Yes, we can see.
Thank you, ma'am. Thank you, ma'am. Can you see my screen, please?
Yes.
Yes.
Okay. Thank you so much. Thank you, ma'am. So, first of all, I'm thankful to Professor Khalida, who always assign me some topic on the GoRed for Women Forum. So I'm happy to be part of your family, though I am the obstetrician and gynecologist, but being an obstetrician, I would happy and to work with you people. So my topic of discussion is the reproductive health in women with congenital heart disease. Is first speaker tell that the prevalence of the congenital heart disease in the pregnancy is rising due to improved survival of the patients with congenital heart disease in the childbearing age. The congenital heart disease affects the reproductive health in women, and addressing fertility and reproductive health challenges vital. Ma'am Najma Patel already described all the health issues related to the reproductive health in the woman, but this my presentation is only the summary of Madam Najma Patel's presentation. So this is just like a summary. So WHO divide the maternal cardiac disease into four classes. The class 1, which carries a minimal risk, including the small VSTs and the repaired ASTs, it carries a minimal risk. The class 2 and 3 carries a moderate risk, which includes the repaired teratology of pillars. The class 4, may request please other audience को keep your mic on the mute, please. Class 2 and 3 carries the moderate risk that includes the repaired teratology of the pillars, and the class 4 that is very high risk, and it includes the Eisenmenger syndrome. And in this class, in the class 4, the pregnancy is totally contraindicated and it's very risky for the mother life. So what are the impacts of congenital heart disease on the reproductive health? The overall cardiovascular system, there is the congenital heart disease impacts overall the cardiovascular system, which can indirectly affect the reproductive health. There are certain physiological changes, there are certain hormonal changes, and there are certain systemic changes, and the medication used by a woman who has the congenital heart disease will impact the reproductive health. These include the poor oxygenation may impair the ovarian function. Because of the sinuses and poor oxygenation will impair the ovarian functions, and ultimately the follicular development that will address associated with a reduced fertility, and even the premature ovarian insufficiency, irregular menses, and early menopause. So these women also experiences the limited exercise tolerance and chronic fatigue, which may indirectly affect their ability to conceive or carry a pregnancy to term. Cardiac dysfunction in the woman who has the congenital heart disease may develop the cardiac dysfunction, making the conception and pregnancy is very high risk. Some women develop the pulmonary hypertension, which can cause vascular complications affecting the uterus and implantation of the embryo. Hormonal changes that are best described by Ma'am Najma Patel. So in the woman with congenital heart disease, due to chronic hypoxia or due to malnutrition, they can affect the hypothalamic pituitary axis that regulates the reproductive hormones, especially the gonadotropins, FSH and LH. They are responsible for the maturation of the follicles and ovulations. So many women with a congenital heart disease on the medication, they are using the anticoagulants, beta blockers, diuretics that may interfere with the hormonal balance and reproductive function of the woman. There are certain nutritional deficiencies, especially the folic acids, that are also necessary for the development of the embryo, the normal development of the embryo. These women have the difficulty in maintaining their healthy BMI, either due to the cyanotic-related underweight or sedentary lifestyles. These leading to overweight, both of which can affect the ovulative function, and ultimately the clinical implication are the delayed puberty, delayed menarche, amenorrhea, menstrual irregularities, anovulatory cycles, infertility, and premature ovarian insufficiency. So what are the key recommendations in managing the congenital heart disease in women with reproductive health? The preconception planning, multidisciplinary care, individualized risk assessment, and contraceptive counseling. The preconceptive counseling is very essential for the woman with a congenital heart disease to ensure the safe pregnancy outcome. It involves a risk assessment, multidisciplinary input, medication review, risk communication, lifestyle optimization, psychological and social consideration, planning and monitoring of the pregnancy, and the menopause. What are the risk assessment? This is the CARE-PREG 2-score systems, which consist of their disease and their functions. Each points have their predictions. If the point coming to the 0 to 1, there is 5% of the risk. And if the 2 points, 10% risk. If 3 points, then 15% risk. Or if the points are more than 4, the risk is the 41%. So assess the risk. What type of the disease he is, what's the severity of their disease, and in which class she is followed in the WHO class 3, 4, or 1, and the status of the heart. So risk assessment is very important before going to pregnancy. The multidisciplinary or collaborative care for the women with congenital heart disease is very important. This would include the obstetrician, the maternal and fetal medicine specialist, cardiologist who has the expertise in the pregnancy and the heart disease, obstetric anesthesiologist, nurses, physicians, and assistants. These all may play a very important role in managing the congenital heart disease. Medication review must be important in the preconception counseling. These are including the teratogenic risk assessment, avoid those drugs which are teratogenic, especially the warfarin, especially the SE inhibitors. So these should be avoided, or posentone. So this should be changed into safe alternatives by a cardiologist, and their dose adjustment. Try to decrease the dose, but don't affect their cardiac status. So avoid the polypharmacy, and patient education must be important. You should, cardiologist must educate the patient that these medications are necessary and why we are changing this to safest drug. These are teratogenic drugs. If we continue this may cause a problem to your baby. So patient education is also very important. What are the risk communication? We must counsel in the preconception counseling that pregnancy and reproductive risk associated with the congenital heart disease. The women who have this problem may have the maternal risk and fetal risk. We clearly explain that there is the risk of heart failure, arrhythmias, thromboembolic events, and maternal mortality. We clearly tell them the fetal risk, the prematurity, intrauterine growth restriction, and genetic inheritance. So the woman who has the class 4, like Eisenmenger syndrome, the pregnancy is very risky for her. Even she may die during the pregnancy. So pregnancy is contraindicated in these type of the diseases. We should advise them preconceptionally the lifestyle modification to stop the smoking. Sometimes the women who are from the villages, they are smoke the hookah, bidi, cigarette, and they are addictive of the pan, chalia, or whatever. They must take a healthy diet. They should avoid the junk food, and they have the regular exercise. Though they are not able to do extensive exercises, but regular walk they should be advised. These women have this congenital disease through her childhood, so they have some psychological implications. So these women need the anxiety addressing and depression related to fertility and the pregnancy risk. There is importance of the peer support and counseling through their family, through doctors, through their peer, and through their families. So what are the planning and monitoring of their pregnancy? Who, what, when, and where, and how? There are 4 and 5 questions. So assess the patient risk conditions. I already discussed that Carpreg score 2, and identify the pregnancy heart team. When the delivery has been done and how it would be done. So delivery, vaginal or cesarean, that's depend upon the patient cardiac status. Usually we recommend the vaginal delivery until unless the cesarean section on the obstetrical grounds. When it should be, it's a term or early term. That's also depend upon the patient cardiac status. If the mother is at risk or she developed the peripartum cardiomyopathy, we may terminate this pregnancy earlier. So where it should be at a center where the all facilities for the cardiac ICU is present. So postpartum management is also very important. We have to restrict the fluid and avoid the ergometrics, which are associated with the high blood pressure. So assisted reproductive techniques, as I already told you, these women have the risk of the infertility and anovulatory cycles. So how they conceive? ART is safely considered for the women with congenital heart disease in the type 1, type 2, and type 3. It should be avoided in the type 4. Why? There is avoid the hyperstimulation, ovarian hyperstimulation, and avoid the multiple pregnancy. Is ovarian hyperstimulation syndrome involves excessive ovarian stimulation. This will lead to the large ovarian cyst, fluid shift, and potential thromboembolic complications. These women are already compromised, and there is already at stress. Pregnancy pose this more risky, and even the ovarian stimulation make this woman more risky towards the heart failure. So women with congenital heart disease are already at a higher risk of cardiac strains, and this would be exaggerated by ovarian hyperstimulation syndrome. What the Royal College of Obstetrician and Gynecologists recommendations for the fertility. So these women may reduce the mild stimulation protocols in which we use the low dose gonadotropins or antagonist protocols to minimize the ovarian response, and cycle monitoring, frequent ultrasound and hormonal monitoring during ART to prevent the ovarian stimulation and to prevent the multiple pregnancies. If there is the risk of ovarian hyperstimulation, then we will freeze all the embryos to avoid the complications and delay embryo transfer until the patient is stable. So after the ART and pregnancy, now the role of contraception and the family planning in a woman with a congenital heart disease. Safe methods. These women asking from us, what is the safe method of contraception? So progesterone only pills is the safe. All the contraceptive which contain the progesterone only pills, the Mirina's, the injections, these are safe. The woman, combined oral contraceptives. In a woman with a cardiac disease, the high dose combined oral contraceptive pills are contraindicated, which contain the higher doses of the estrogen and making them more prone towards the thromboembolic state. So low dose oral contraceptives can be advised in the WHO class 2 and 3, but it's totally contraindicated in the Eisenmenger syndrome. Coming to the menopause, menopause is best described by Madam Nachma. So there is the risk of early menopause, premature ovarian insufficiency, and these can be overcome by giving the low dose estrogen replacement therapy and advice for the regular walk and diet modification and the calcium supplements. What is the conclusion of this today's presentation is individualized care is essential for optimum outcome. Pre-conception counseling and multidisciplinary approaches are very critical. Balancing maternal and fetal risk ensures the safe pregnancies. So these are references from Royal College of Obstetrician and Gynecologists, the NICE guidelines, and sexual and reproductive health guidelines, contraceptive choices.
Thank you, Dr. Shabnam, for your valuable presentation. She spoke on reproductive challenges and fertility consideration for the women living with the congenital heart disease. Let's proceed to the questions from our chairpersons.
Assalamu alaikum, Dr. Shabnam. That was this is Dr. Manaz. Very comprehensive talk, and you have addressed practically everything. I just have a few comments, if not questions. One is that in the preconceptional counseling, we should always tell the husband, wife, the family that there's a high chance that the patient's preconceptional status will become worse after the baby is delivered in the postpartum period. I mean, she may, that is one thing that she needs to understand. Her status may not be the same later on. There's a high chance of a deterioration. Second is obviously you monitor pregnancy very nicely, you deliver the baby, and then it's the postpartum immediately. The first week after postpartum again is a high risk for dying also because of thromboembolic. And infective endocarditis prophylaxis has to be given to all these patients. Especially the cyanotic heart diseases and the unrepaired hearts, you need to give infective endocarditis prophylaxis. If that is, I want to ask you, do you give? I mean, should you be giving it only in vaginal delivery, or you should be giving it in epidural and other modes of delivery? That's my question to you.
Ma'am, we are not giving it regularly, but if the woman who is undergo the cesarean section, then we have to give it antibiotic cover.
I think IV prophylaxis is indicated, Dr. Shabnam.
Okay,
because,
yeah. I shall add in my presentation too.
Yeah.
Thank you, ma'am, for guidance.
Sorry, one comment. Like postpartum period is more dangerous in first 1 week. So any patient who has compromised heart should be kept admitted after delivery for at least 1 week.
Yes, ma'am. They are admitted.
That's what I'm
They
saying.
are
They
mutated.
have a high risk of dying in the first week after
First
postpartum.
week of pregnancy, they have a very high risk.
And
They are
it is
admitted
it is
environment.
recommended that depending on their status, depending on their Carpenter scores, you have to probably put them in the ICU for the first few days after delivery.
Yes, ma'am. We are doing
One
it.
more point I want to add is that after 1 week postpartum, it is very important to follow these patients closely in the 4th trimester also, that is up to 6 weeks, because anything can happen. A woman with congenital heart disease who has delivered, who has become pregnant. Hope, Shabnam, I'm correct in telling you this.
Sorry, ma'am.
Can I ask a question, please?
Yes, please.
My question is that I'm already putting that why MBBS public health physicians are not the part of multidisciplinary, because they can do lifestyle education. We are all into the fixing the problem. We are a nation where we don't prevent diseases. It is very sorry I'm saying that. I mean, we create big problems and we spend millions to correct them, but we don't like public health doctor to be a part of it. Nutrition can be done by public health doctor. There is no need of the nutritionist. There is no need of social worker. A MBBS physician is much better part of a team than to be having people who don't have the MBBS degree. Throw light on that, please.
Sir, MBBS doctor, no doubt they are very good and they are helpful in the screening. But nowadays, the Benazir program of community midwives, they are going to the communities and they are taking detailed history and they will screen. So we are
But this
just
would work
we are
under
just treating
the
them.
future.
No doubt, we are just
It is
treating them, but we must be a preventer. So we are
no, I
doing
have to
this.
be advocate. No, you can't do that. It means that like MBBS 3 years trained gynecologist can be called consultant. Then we can call every 3 year trained gynecologist a consultant. There is no need for FCPS degree.
Yes, sir, you are right.
Because that physician who doesn't have FCPS but 3 years training like in USA, he is eligible to be called a consultant. It is only in Pakistan you need FCPS. In America and England, if you are trained, you can become a specialist in consultant without MRCOG and without fellow of American Oxford Gynecology. Because my training was in New York. It is trained country have quite working for us, but we won't allow the trained physician who don't have even FCPS. This is very funny.
Yeah, I agree with Dr. Ali Imran on this issue, because most of the time we see our patient later than the general practitioner who don't know about these findings, which were mentioned by the Dr. Menwa Patel and were discussed earlier. So,
Dr. Khalida, I think
Dr. can I make a comment? डॉक्टर साहब ने जो बात की है ना कि अमेरिका में यू डोंट नीड अ डिग्री टू बिकम अ कंसल्टेंट, उसमें वहां का जो सिस्टम है उसके अंदर यू कैन आइदर बी बोर्ड एलिजिबल और बोर्ड सर्टिफाइड, एंड व्हेन यू आर बोर्ड एलिजिबल, just let me complete please, just me complete. Board eligible is somebody who has gone through a proper training but he has not taken the exam. Then he is certified, he is a specialist. However, this person cannot become a teaching staff in any hospital or any medical college. That is there. दूसरी चीज ये है कि जहाँ तक एक मिनट जो चीज जो आप फरमा रहे हैं ना कि पब्लिक हेल्थ वाले को भी साथ मिलाना चाहिए वो द डॉक्टर, एक्चुअली व्हाट इज बीइंग डन नाउ इज even the nurse practitioners are being trained, health visitors are being trained also in this to look after these patients. और उसका फायदा ये है, देखें एक मिनट, उसका फायदा ये है कि जो कॉस्ट है उसको कम करना है. तो अदरवाइज विद मोर डॉक्टर्स,
आप 50
जब ज्यादा डॉक्टर्स होंगे,
with the permission of a chair, can I add?
एमबीबीएस डॉक्टर को बेरोजगार कर रहे हैं। आप जरा देखिए कि एमबीबीएस सब टोटल बेरोजगार हैं, एचसीपीएस पार्ट 1 के उनको पे, यानी हम अजीब नेशन है। तो फिर मत लीजिए, ये एमआरआई और सीटी स्कैन की भी जरूरत नहीं है। हमारी कंट्री पुअर कंट्री है, हमें जरूरत नहीं है एमआरआई।
नहीं, वो और बातें हैं। बात ये है कि देखिए, जब जब आप पब्लिक हेल्थ स्पेशलिस्ट है ना, तो आपकी अपनी डोमेन है जिसके अंदर आप सारे प्रोग्राम्स करते हैं, पब्लिक हेल्थ के कंसल्टेंसीज करते हैं, पब्लिक हेल्थ की आपके WHO के प्रोग्राम में सारा कुछ है। उसके अंदर आपको कोई जॉब के बगैर नहीं कर रहा। अमेरिका में भी जिन लोग सिस्टम में आते हैं, उनके वो पब्लिक हेल्थ वाले लोग नहीं होते, वो ज्यादातर नर्सेस हैं, ट्रेन्ड नर्सेस, ट्रेन्ड।
This is insult to the doctors. It is just like that HCPS हम कार्डियोलॉजी के 3 साल जो पार्ट 2 नहीं कर सका है, कितने मैं लोगों को जानता हूँ जिन्होंने ट्रेनिंग की है NICVD में, पार्ट 2 नहीं कर सके, तो उनको भी फिर कंसल्टेंट कार्डियोलॉजिस्ट कहना चाहिए। वो 4 साल उन्होंने ट्रेनिंग ली है NICVD में, मगर वो HCPS नहीं कर सके। तो आप तो अच्छी बातें कर रहे हैं कि
पाकिस्तान का सिस्टम फर्क है। पाकिस्तान का सिस्टम फर्क है। नो, पाकिस्तान का सिस्टम
It is very interesting discussion, but now we are moving towards our another fourth presentation, that is the last presentation. And Dr. Alia Kamal Ehsan will be delivering her presentation on genetic counseling and inheritance pattern, empowering women with the congenital heart disease. So, Dr. Alia Kamal, are you there? Alia?
Madam, thank you, madam. I would like to share my slides. Is it sharing?
Yes.
Oh, okay, thank you. All right. Assalamu alaikum. The topic, my name is Dr. Alia Kamal Ehsan, an assistant professor, Peds Cardiology at NICVD. Today, currently in Malaysia for Peds Cardiac Imaging Training. The topic of my presentation today is a very interesting topic, and I would like to thank Dr. Khalida Soomro for always, it's basically genetic counseling and inheritance pattern, how to empower women with congenital heart disease. So these are the objectives that we will be covering about the genetic testing, genetic counseling, transitional clinic, risk stratification, and the role of multidisciplinary team in all this. As you know, this is always, most of this slide has been covered by Dr. Masood Sadiq, or as you know, it's very highly prevalent. 90% of the children are now being diagnosed with congenital heart disease and are surviving into adulthood. We do advances in medical and surgical interventions in the last 3 decades. The overall prevalence is around 4 per 1,000. And if you count, these are half of them are women. So those incidence of pregnancy in women with congenital heart disease is rising. It's around 2 to 4%. And it's very, this paper in Canadian Journal of Cardiology, it shows steady increase in adult congenital patients throughout the life, with time, and it's says that it's a growing epidemic now. Now, the topic of my presentation for genetic counseling. This is a very nice paper about genetic counseling and testing in adult congenital heart disease from preventive cardiology. It embarks on why do we have to do this. Because genetic counseling, even if we do it, majority of the patient ask, why are we doing it? What is the basis and what is the outcome? So basically to confirm the diagnosis, and then the guide management, which has been discussed with Dr. Najma Patel and also by Dr. Shabnam. And what about the long-term prognostic information, the recurrence rate, and genetic risk assessment in the family members? Because if there's certain diseases that have higher genetic predisposition, they range from those that range from around 1 to 50%. So they have high prediction in families. When should it be done? It should be done in transition clinic, number 1, in pre-conceptual, before getting pregnant, and in older patients who have no previous counseling. Who should do done this? They should be done by a genetic counselor in collaboration with an adult congenital multidisciplinary team. How do you diagnose this? CMA is the first line test for undergoing genetic counseling, and rest can be done if needed. Now, according to AHA and ESC, this is the guideline for adult congenital heart disease. They have embarked on this multidisciplinary approach for patients with congenital heart disease for genetic counseling and genetic clinical geneticist. They embarked on cardiac development, cardiac genetic testing, and strategies for recurrent risk counseling and family risk assessment, which is very important, a need of the hour. Okay, as you know, the risk, if any one patient for any isolated congenital heart disease, 2 to 3%. If one child is affected, it increases up to 50% if two generations are affected. And it's much higher in when the mother is the affected parent and then the offspring. And there are different studies done by the Danish population which shows that those with heterotaxy, left-sided obstructed lesions, they have higher risk, recurrence risk as compared to the others. And for those who are asymptomatic because of pleiotheric phenotype, this will also determine the recurrent risk in the future generations. So, and some are single gene disorders, while others are autosomal dominant. And this is a very nice table, which is showing the affected, if the father is affected, then what is the recurrent risk? As you can see, it is much more higher in mothers. And if two siblings are affected, then when fathers and one sibling is affected. Okay, we cannot, unless when we take counseling, we have already discussed that they have to be done at multiple levels. And they usually come to us at very late time. Usually, according to AHA, when the patient is up till 18 years, that should be followed by a pediatric cardiologist, and after that by the adult cardiologist specialized in it. And they should be stratified into three levels: those who require exclusive specialist centers, those who have can be established with the appropriate general adult cardiac services, or who can be managed in non-specialist clinics with access to specialized care if required, and it determined not only by the classification of the disease, but also by the complexity and the hemodynamics. And these are because this is a very nice paper on ESC. It was published in 2023, showing that the survival, and the one in AHA, in which they showed that the survival and morbidity, both with a very simple defect like VSD, is long-term. And they have an additional set of complications as in respect to age-related normal population. So even if it's a very small defect, it can have long-term prognosis and long-term effects, and they have a very additional set of complications. This is a paper done in our own setup at NICVD, frequency and pattern of adult congenital, showing the burden of this disease and the complications that shows, and they have a very high risk of heart failure. Okay, when you are going for genetic counseling, then in these transitional clinic, there should be a detailed medical history of a family member, at least spanning 3 to 4 generations. Consanguinity should be documented, genetic testing should be advised, and a phenotype should be recognized on chromosomal syndrome. And those who are having genetic facial dysmorphism, skeletal defect, vessel organ malformation, growth delay, or developmental delay or psychiatric disorder, or family history, or more than one first degree, they should be advised genetic counseling. This is a very nice algorithm showing in this genetic paper. They're showing that if there's first we have to determine if there's syndromic congenital heart disease or not. If it's yes, it's syndromic recognizable phenotype, then you can go for counseling and targeted testing. And if you know the suspected gene disorder, aneuploidy or CNV, then you can go for first line normally genetic testing at CMV. If it's not, then counseling and targeted testing is required. If it's negative, then you can go for fish analysis also. It's hard to determine. The result is also very hard to tell the parents. If there's no syndromic and the family history is positive, then you can go for a suggestive gene disorder like fish. If it's not, then you can it can be a sporadic case, so no genetic testing is required, and then you have to evaluate the family history. This paper, very nice genetic counseling paper, it embarks on these important points. And what are the differentials, which testing like CMA is the first line test. If additional test is required, then you can go for whole genome sequence, whole genome sequences, and other non-invasive cell-free fetal DNA. Okay, they also normally we classify congenital heart disease on the basis of physiology and surgical. But when in this paper, they also classified in the basis of immunological development as it into 7 categories, and the risk is documented according to that. For example, for anomalous venous return, ABSD, complex, monotopical, heterotaxy, LVOT. LVOTO is very important. It has a very high recurrence rate in the family, and sometimes very, very, very hard to determine prenatally. This is a very nice, this is a graphical representation showing multifactorial is the most highest. It's basically this is undetermined. It may be a combination of genetic and environmental factors, followed by genetic aneuploidy, and then environmental factors that can be mother-related, drugs, diabetes, and other factors. All right. When should the counseling be done? If it's not done at a transitional clinic, it can be done on a fetus with congenital heart disease identified. Main challenges are about if the child has a bicuspid valve, it's very hard to determine the fetal echocardiogram. So a lot of times you cannot predict the recurrence risk in the generation. Preconception counseling and assessment has always also been talked about. It's a multidisciplinary management. The only thing I would like to embark is it's an ECG, echo, and exercise tolerance test should be performed in such women. And also, if they have an orthopathy, they should be followed with CT or CMR. And pro-BNP has a very prognostic value after 20 weeks. Preconception counseling, ESC guidelines have developed this in 2018, multidisciplinary approach, especially pregnancy heart team, and the recurrence estimation by WHO classification. All right, why preconception counseling is important? Because majority of the patients that we encounter are in this preconception group. It is also the cardiac event to the mother and also the obstetric complication that can happen pregnancy. When we are discussing about the prenatal diagnosis, the fetal risk is very important. There are various indications. If there's a congenital heart disease, if there's a diabetic mother, and so many things, then we should go for a fetal echo. It should usually be done at between 15 to 22 weeks. And we can also advise pre-genetic testing, like in chorionic venous sampling or amniocentesis, but be aware that even if we do this, the result comes late. And if they have any outcome, because normally the abortions are advised for mother complications, not for the fetus. And then risk stratification, as we have already discussed, the biggest, the most important is WHO classification. Then there's the Carbeck, Zahara score, and ROPAC registry. WHO classification is the most widely used, and it is those experts in British have also consensus about working on the most useful and most accurate classification system. It divides the congenital heart disease from the mild to the severe. As you can see, then the counseling is required throughout this. But if you start with WHO class 1 and go up to 3 or 4, then 4 you have to also go for termination of pregnancy. But according to new guidelines, if the parents do not want a termination of the pregnancy, then they can go for expert delivery in expert centers who are basically they have this heart team. This is a very nice registry. This is a very nice registry. It is the largest one in pregnant women, spanning over the 10 years from 2007 to 2018. It took up observational registry of pregnant women with congenital valvular cardiomyopathy and ischemic heart disease with a mortality rate about 0.6, which was much higher than normal pregnant. This was also higher for for those with pulmonary hypertension, cardiomyopathy. The ones with congenital heart disease had a mortality rate of only 0.2%, which was better, but they had heart failure, those especially with complex, rather than simple or moderate. And the best part they saw is that the rate declined, especially after 2010 in the emerging countries, because the clinicians and the clinicians got more aggressive with the treatment, and they were much more comfortable, and the parents were counseled, and the outcome were improved. So preconception counseling and optimization, that has very much impacted the outcomes in these women. Then these are the various classifications that have a risk scores that have been also discussed. Always remember the maternal mortality for these GOHs is 18 times more than the normal counterpart. And cardio ops is an emergent field. They basically have these valvular spectrum of cardio ops emerging from valvular heart disease to congenital to acquired, the coronary and arrhythmias. They have these 9 pillars in which the preconception counseling, maternal imaging, antenatal testing, genetic counseling, fetal echo, planning of delivery, spontaneous versus induction, placental ultrasounds, and postpartum cardiac monitoring and conception. These are very important points. Our experience, most women are diagnosed first time during pregnancy. Sometimes parents even hide the facts. Many are diagnosed after multiple pregnancies. Some are referred in the 3rd trimester, which is high risk for even those patients. Counseling to those who are diagnosed earlier is not done properly. Even if the counseling is done, parents do not follow that because of social constraints. Couples, when aware of the problem, do not avoid pregnancy, even it has been advised, but surprisingly, they are ready for abortion. Thanks to, I would like to add that we have started a cardio ops clinic in NICVD. This was started in Feb 2023, and it is in collaboration with adult cardiologist, obstetrician, pediatric cardiologist, anesthetic, and electrophysiologist. Over 200 patients have been referred to this clinic, and 95 have been with structural heart disease, and 20 who had contraindications to pregnancy. The director of this program is Dr. Hannah, who is an MD from America. And these are some patients that we have basically gone through. 19-year-old with, I would like to go through just to tell us the spectrum of this disease and this outcome. 19-year-old with increased shortness of breath in the 2nd trimester, clinical examination with diastolic murmur, ECG was normal sinus, tachycardic with MS and rheumatic heart disease. She underwent, she was in functional class 3. Then in the 2nd trimester, her PTMC was advised, and after that, her functional class improved, and also she had a good outcome, and now the baby and mother are both alive. Then there's another case of TOF, repaired at 15 years of age, now presented at 30 years of age at 28-week gestation with severe pulmonary regurg, dilated RV, mild RV dysfunction, and mild AR. She was discussed for surgery, but resisted, and then she was offered delivery in our NICVD with general anesthesia, with cardiac anesthesia, and finally her PVR was done. Surgical PVR was done. 3rd patient was a status post AVR with coarctation stenting. There are 7 weeks of pregnant with twins landed in the ER with struck valve, and the gradient of PPG of 70 and MPG of 70. Underwent redo AVR, complicated by complete heart block. Solve was placed, and also diagnosed as APLA. So she was finally, now she's currently at 8 months, and twins are doing well, and that was really a miracle case. And lastly, I would just like to add, there was a PDA, unrepaired PDA with pulmonary hypertension. She was advised closure, but she did not go for it. She came to, even in the 1st trimester, when she was advised, she did not go for it, and she even ran away and landed in our own OPD at 30 weeks with class 3, with non-compliant to medications. Then she was started on pulmonary vasodilators, basically saltinafil, and oxygen. And now she was delivered, and now she, alhamdulillah, she is a mother of a primary, she was a primary gravida, and she's a mother of a 6-month-old. Thank you so much.
Thank you, Dr. Alia. for your insightful presentation. Let's now proceed to questions from our chairpersons. Any question, Dr. Ambar Ashraf?
Assalamu alaikum, ma'am. Thank you very much. I was really appreciating all the talks, but something which is very practical and important, that was third talk of Dr. Shabnam, I think so. She's a gynecologist. Basically, that is the need of the day. We all should have these cardio ops clinics in our teaching institute. At least we are working in Khyber Teaching Hospital since 2020, before the COVID, and there are so many the young females during their pregnancy. They come across with the simple sign symptoms of shortness of breath, palpitation, generalized edema, hypertension, diabetes. No doubt, the pregnancy adverse outcome is an emerging field, but that regarding the congenital heart disease, which become apparent during their not in the first pregnancy, second or third pregnancy. So from the Pakistan Cardiac Society platform, our president is here. We must have to start these type of the clinics and the proper guidelines for whole of the country. That is the need of the day. Second important thing over here, the genetic counseling and things like this. There are so many patients who can afford it. If we know the subject very well, we can offer that genetic counseling to our patients who can afford. No doubt, it's a costly modality, but that's very important. We share this knowledge with the rest of the gynae people, the cardiology fellows, and the people so that we can apply it. Just want to highlight one important things. If we go to our peripheries, like in the Cape, and in the peripheries, we come across there are so many healthcare professionals who are providing these services. That's not only the MBBS doctors, there are the midwives, as well as the healthcare professionals, the nurses, and there's a full programs where the family physicians and the public health people are working. Those who are not working here in Pakistan, they are not very well aware of these programs which our governments have with the full planning. They are learning these, running these type of the programs. So the best thing is we all should have to put our own drop of water so that we can look after this disease prevalence. And the congenital heart disease, ma'am, congratulations to you. The way you are motivating all of us, and we are conducting different workshops and programs in this, and that's really a wonderful session. Thank you very much.
Alia, there
Yes,
is
madam.
one question for you. That is what are the ethical considerations when discussing the genetic risk with the patients? Ethical consideration.
Yes, ma'am, that's the biggest problem. Even if even if we diagnose a patient with congenital heart disease, and even if we offer them a chronic wave sampling or genetic testing, the biggest problem that we see is that if are we going to offer them abortion or not? Because even in Pakistan and areas, we do not offer abortion for fetal problems. We usually offer for maternal health or mother life. So when we are counseling parents for them, mostly of them, first of all, these genetic tests, although they are expensive, and but they are also time consuming. They take around 90 days even to recover the test. And if this test also changes the outcome, usually it doesn't. We can advise the parents and can tell them about it, but if you can say if it's safe or if it has any prognostic value, so cannot say. And the second thing is when we are doing the fetal echo, sometimes it's very hard to determine if there's any, we discussed like bicuspid valve or sometimes. It is so genetic counseling becomes a little hard at that time. And then those who are isolated, because this adult congenital palindrome, it is very new. their recurrence rate and everything, they are determining at this moment. So we don't have that much data regarding how much risk, and of course the risk is determined also by the consanguinity and how long the parents have, and how many generations the disease has been, and also if like Bato classified it into different groups. So there are so many ethical considerations.
Any Dr. Najma? Any comments from your side? So now, due to unavoidable situation with Dr. Shoaib's side due to the death of her father, we cannot, she is not presenting her topic today. So I invited Dr. Professor Rajkumar Santivani to give comments, some comments regarding her topics today. Dr. Rajkumar. Our topic was how can clinician, the question from the Rajkumar is, how do you recommend incorporating contraceptives counseling into routine care for the congenital heart disease patient? And I would like to have your comments on the
Are you getting Are you getting my voice, madam?
Yes, we are.
Thank you very much for asking a nice question, because this is a routine problem with us that we have been observing a lot of patients who are put on contraceptives, but they are not guided properly or counseled properly that how should they maintain their INR. Because we have been telling them, if you are having rheumatic heart disease, especially, which is still prevalent in our society, though this seminar was on congenital heart disease, but you asked that most of the patient having mitral valve disease and having atrial fibrillation are coming to us with after development of stroke. So that is the best thing, that we must hammer in their brain how to maintain their INR. And when the lady becomes pregnant, then it's an ideal that we should ideally keep the patient either on subcutaneous unfractionated heparin for throughout the pregnancy period, or we should counsel them properly that after 6 to 12 weeks at least they should keep constant. They should have a subcutaneous, or there are a lot of defects in fetal because they are fetotoxic as well, and they are causing a lot of problem to the female, and whole life patient and the fetus are suffering from congenital heart disease. That is the main thing. Regarding today's talk, I will appreciate that all the speakers were of a high class and high standard. Professor Sabhabati nicely talked on cardiac imaging for congenital heart disease. Especially, she highlighted the role of cardiac MRI. That's very much, that I think cleared a lot of concepts. And Professor Najma Patel, the very renowned cardiologist, especially and the congenital heart disease, he talked very nicely on hormonal fluctuations, because this is very much important that we must tell the woman that what are the effects of the hormones when they, especially they become pregnant, and they are across the female life span, they may play a role. Dr. Shabnam Nas rightly talks that heart disease and fertility woman, and she also insisted that preconception important, and that is why, as you all already said, madam, that how can we motivate our GPs, and that is the best way you have been doing that, more and more seminars, awareness program, especially in their local languages, that they should get concept, because general practitioners, a lot of things go beyond their mind, so they do not concentrate. So I will pay once again thanks to all the speakers, and Alia Kamal Hassan also talked nicely on the genetic counseling. That is very much important, that we must counsel if the patient is having problem in their families, and when she becomes pregnant, we must counsel, and preconception counseling plays very important role in this. So thank you very much, all the speakers and the panelists. Thanks a lot.
Dr. Rajkumar. Dr. Hasina Chagani, I can see on the screen, and Dr. Madia Fatma. If they are available, please give your comments. Or if you are having any question in your mind, you can ask from our speakers and the chairpersons.
Assalamu alaikum, madam. I am Dr. Hasina Chagani. It was really very nice to attend this symposium. It was my first attendance in this symposium, GoRed, but I am really impressed with everybody whosoever has presented. They have made the concepts of all of us very clear. I hope more people can attend this type of seminars. Thank you, madam.
So, any more comments from
आलिया के लिए क्वेश्चन है. Can I ask with your permission? आलिया के लिए क्वेश्चन है. Can I ask Alia a question with your permission?
Yes, you can. But brief, because we are
Where
going
is
to
Alia?
end.
Has she left?
No, ma'am, I'm here. You can always ask, ma'am.
आलिया आपके लिए क्वेश्चन ये है कि एक तो थोड़ा सा हाईलाइट कर ले कि you are by your lecture it showed that every patient with congenital heart disease should undergo women undergo genetic counseling, pre-conception and genetic testing. Every patient, regardless of the severity of complexity of the congenital heart disease?
Ma'am, the thing is, it depends on the
आप
actually.
थोड़ा सा अगर बता दें हमें कि किन पेशेंट को हम लोग को जरूर भेजना चाहिए for genetic counseling and testing.
Ma'am, खास तौर पे वो with moderate to severe, those come in WHO class 3 and 4, they should be sent for genetic testing and counseling, because according to team dynamics and AHA guidelines, they have been specially targeted for management. And then those who have left-sided lesions like LVOTO and bicuspid valve, and those they have high genetic predisposition, more than 50% in the family. They could also benefit from genetic counseling and testing.
Dr. Radha,
very good explanation. I liked it. Your answer, I really liked it. बहुत relevant answer.
Thank you so much, madam. It is always a pleasure and delight.
So, can you give your comments on this topic, Radha?
How much it costs in class?
Very nice presentation.
You don't have to smile to say that.
I will ask our chairperson to give brief comments on this webinar. It will give some message for the public, because this webinar will be saved on the website of the Pakistan Cardiac Society forever. So we would like to have your comments. Dr. Zainab, if she is present, I would like to have her comments also.
Madam, if you are getting me.
Yes, you can.
Madam, I would like, since I have become the president of Pakistan Cardiac Society, so I would like to have these type of seminars in the hook and nook in every corner of Pakistan, especially in all the districts of Pakistan. So during my tenure, I would request you to come to Sakkar, Larkana, and give us time that we should have a live seminars over here, and in a local language.
Yes,
should explain all those things to the poor doctors as well as the masses. Thank you very much.
In the peripheries and rural areas, even GPs and lady health visitors, these people need education and awareness themselves. We are talking about the patient's awareness, but we know that there is some problem at the level of our GPs and the paramedical staff as well as lady health visitors who are there. Even they don't measure the blood pressure at this level. So we have to do something for them from the Pakistan Cardiac Society platform in our peripheral areas. Dr. Ambar Ashraf?
Ji, ma'am, thank you very much. That's what I've already highlighted, and I think of the day. The one thing from the society platform, especially from the GoRed you are doing, I'm trying to have all these type of the workshops and symposiums here in KPK. They people should train, that is hands-on training regarding a very simple measures, as you said, regarding the blood pressure, how to check a random blood sugars, how to take up complete body weight and educate them, because these are at the time existing resources, because we are resource limited country, we don't have enough budget to formulate another type of the full fledged program for this. Why not to utilize the same existing human resource and train them so that they can look after this thing? Another important thing, the young pregnant females, whenever they come across, the GPs should be trained. At least they can ask a detailed history from them, and if they are symptomatic, they can refer them properly to a cardiologist so that they have a simple echocardiography and ECG. If blood pressure check, ECG, and if the females pregnant, they are symptomatic, they should be referred for the echo. If we can have this simple checklist, it should not be very elaborative, but at least we can take a first step to go ahead. Second important thing, our PGs in FCPS Part 2 training programs, they are not focusing on this topic at all, because all of them are nowadays happy to work with the wires and catheters, but that is the 50% of the cardiology. The women population is there, and the female population is increasing day by day. So this is very important. At that platform, as a supervisors, as a teacher, we all should have some type of academic activities in our units, so that when they are coming budding cardiologists, they go and serve in the peripheries on the district level, they have a basic knowledge of this component, so that they can organize and have some planning at their district level to train the rest of the MBBS doctors, the nursing staffs, and the thing. In this way, I think so we can go forward. And our worthy president is here, and he is very innovative ideas. Why not in the next year we come across such type of the activities with the help of different pharmaceutical companies? Thank you very much, ma'am, for highlighting this very important topic, which is the need of the day. Thank you very much.
Dr. Radha, what about your country? You have listened us, and what are the major differences in between Sri Lanka and that is also low income country? Pakistan is also low income country. I think the situation is
He is mute. I think unable to hear.
so. Dr. Abdul Sattar?
Yeah, madam. Basically, I need your 2 minutes only, ना. जो basically हमारा personal experience है हम लोगों का for the adult congenital heart disease, especially women with congenital heart disease. उसमें last time भी हमने बहुत कोशिश की थी कि with help of the different gynecologists, even हम लोगों ने चांडका में लाड़काना में भी वहाँ अप्रोच किए थे, सखर की तरफ, हैदराबाद, टनों खान, कराची में, जिन्ना हॉस्पिटल सिविल में, कि we should make some policy, at least local policy, local guideline. They which type of mother needs which guidelines and how we have to proceed for the pregnancy and its complication. Because even आप simple देखेंगे JPMC civil hospital, they are even reluctant to take any pregnant mother with the severe pulmonary hypertension, heart failure, arrhythmia, or other cardiac related complication, they remain very reluctant. और उनकी mortality भी हमारे पास very high mortality रही है अगर if they are taking this. Why many times they are saying, okay, we are unable to manage these pregnancies at general public hospital levels. So many times we are taking care of these mothers and bringing them to NICVD or other tertiary care hospital who is already with the cardiac setup and doing the deliveries. Like at NICVD, we did many deliveries of these mothers. Dr. Alia is also part of this cardio ops team, along with Dr. Hanna, Dr. Sabah, and Dr. Veena. So many mothers are coming and saying that no one is taking care of us and no one want to enroll these patients because they are saying we are not well aware about the complication, how to manage these pulmonary hypertension when mother is in the tertiary third phase of labor or at the terminal stage. Because this pulmonary hypertension, if not treated properly, their mortality is almost 100%. Fetal mortality and maternal mortality. It's also indication for the termination of pregnancy. If, for example, any high-risk mother with a very high-risk chance of termination of abortion and a maternal complication, there we are advising them the termination of pregnancies. But most of the these gynae ops people are even at that time they are saying we are very concerned about the complication and risk during the termination of pregnancy because during termination of pregnancy is also very high risk for these mothers. I think Dr. Shabnam can comment on this. At least in these centers, at least in the Lakana, Sakhar, they can do. Because at the early stage of the pregnancy, if these mothers with severe pulmonary hypertension, severe heart failure, arrhythmias, pulmonary edemas, or cardiomyopathy, if they continue the pregnancy with the progression of time, there's a high chance of complication, high chance of maternal death and fetal death. But also, if we are advise them for the termination of pregnancy, then even Dr. Shabnam even then comments, this is also very risky process. And most of the gynae people are refusing that we will not take care, we will not go for this procedure, and they go for the any high quality, high equipped center like they are advising for private centers, even including in the Karachi, main city. Even from the Jinnah Hospital, Civil Hospital, they are saying, okay, we are unable to manage this patient. Our anesthesia people are unable to manage these patients. So I'm still.
Sir, sorry, can I answer, Sattar?
Yeah, yes.
सत्तार आपने जो कहा ना कि अर्ली अगर आप फर्स्ट ट्राइमेस्टर में अगर आप इनको टर्मिनेशन के लिए कहें ना हाई रिस्क पेशेंट्स यू हैव टू डिटेक्ट देम इन द अर्ली प्रेगनेंसी पीरियड एंड टेल देम टू गेट अगर फर्स्ट ट्राइमेस्टर में हो जाता है तो एवरीबडी डज वेल बट इफ इट इज मोर देन फर्स्ट ट्राइमेस्टर देन द रिस्क सिग्निफिकेंटली इंक्रीजेस।
मैंने यही कहा कि फर्स्ट ट्राइमेस्टर में हम उनको एडवाइस करते हैं सबसे पहले कि इफ फॉर एग्जांपल एनी फीमेल हु इज in the pregnancy childbearing age, we are always counseling to mother, father, and the this young girl that if before the marriage, please bring your partner to our clinic so we can sit together and make some policy. Because marriage is not contraindicated for these patients. But pregnancy is many times contraindication for this patient. But जो हमारे सोशल नॉर्म से आपको पता है कि वो ये कहते हैं कि अगर हमने बता दिया उसको मेल्स को तो वो सीधी बात है शादी नहीं हो पाएंगी। उस दौरान क्या होता है प्रेगनेंसी हो गई and they suddenly presented in the after pregnancy that now patient is developing a complication like Alzheimer's patient which is coming in the first trimester always complaining for the shortness of breath and worsening of the cyanosis. जो उस टाइम बैठ के अगर उनको काउंसिल भी करते हैं कि दिस इज वेरी हार्मफुल फॉर द मदर एंड हाई चांस ऑफ मैटरनल डेथ, तो इवन इस टाइम पे मोर देन 50% स्टार्टिंग में फेस में होता है कि वो उसको एक्सेप्ट नहीं करते और कहते हैं कि हम ठीक है विजिट करेंगे, मोस्ट ऑफ टाइम दे आर वो लास्ट ऑफ फॉलो अप, तो वो फिर प्रेजेंट करते हैं सेकंड और थर्ड ट्राइमेस्टर में जब वो ऑलरेडी कॉम्प्लिकेशन के साथ प्रेजेंट करते हैं। तो इस टाइम पे ये होता है कि सीधी बात है हम तो हेल्प चाहते हैं गायनी ऑप्स वालों की कि हम किस तरह मैनेज करें, क्योंकि ऑलरेडी फर्स्ट ट्राइमेस्टर है, अगर टर्मिनेशन हो जाती है, जो कि मोस्टली 20% से ज्यादा फैमिलीज ऑप्ट करते हैं। वो अगेन मेजॉरिटी जो है ना, वो सी बात रिलेक्टेंट होते हैं कि अगर फीमेल के बेसिस पे कि शी इज अ डिजीज है और उसको हम उनके ससुराल को बताएंगे तो सीधी बात है वो हो सकता है कि ब्रेकअप हो जाए। अब वहां पे हमारी सीधी बात है, मेन प्रॉब्लम जी पब्लिक अवेयरनेस यानी जीपीज अवेयरनेस। इवन कि प्रेगनेंसी हो गई तो मल्टीपल टाइम हो सकता है कि उनको जो भी लोकल जीपी ट्रीट कर रहा है या गायनी ऑफ पीपल्स ट्रीट कर रहे हैं, हो सकता है कि वो भी इतना इन्फोर्सली उनको नहीं कहते कि आप इस फौरन जाएं और टर्मिनेशन की तरफ जाएं, क्योंकि काफी चीजें हमारे नॉर्म्स में नहीं है, माशरे में नहीं है, तो उसको रिलेक्टेंट होते हैं बताते हुए।
डॉक्टर सतार, मैं थोड़ा सा हाईलाइट करूंगी कि आई एम प्रैक्टिसिंग एट द लाड़काना, और लाड़काना is only one tertiary care hospital. ना सिर्फ सिंध से बलूचिस्तान, हमारे आधा और हमारे पास कोई ऑप्शन ही नहीं है कि हम पेशेंट को नो करें। Whatever the stage, whatever the disease, whatever the severity, we had to take in a tertiary care hospital. So NICVD, डॉक्टर फयाज मुश्तबा, डॉक्टर जगत, वो हमारे साथ होते हैं और पेशेंट हमें रेफर करते हैं। इवन हम लोग इंडक्शन उनके NICVD में भी जाते हैं और वहीं पे इंड्यूस करके आ जाते हैं। तो ऐसे केसेस हम लोग डील करते हैं। आई वुड you people start cardio obstetric clinic at the Ladkana. I can lead that clinic with your help. So मैंने आपकी लिस्ट में देखा कि उसमें प्रोफेसर नुसरत शाह आपकी मेंबर हैं इस कार्डियो ऑब्स्टेट्रिक क्लिनिक की, जो आपने कराची में स्टार्ट किया था। Currently, Madam Nusrat Shah is our Vice Chancellor. If Madam Khalida communicate with her, and we can start cardio obstetric clinic at the Ladkana with the help of NICVD and the Sheikh Zayed Women Hospital.
Can I ask something?
Yes, we have even the trained anesthetist, the head of department, Dr. Ahmadin Soomro of the anesthesia. He is the FCPS consultant, and we have a good ICU. Even we have the ICU, we shift these patients to the intensive care unit. So you can start this cardio obstetric clinic at Ladkana. I would be happy.
इट्स बेस्ट ऑप्शन एटलीस्ट जहाँ पे कार्डिक सेटअप है उनके साथ कार्डियो ऑप्स करके, और वी कैन स्टार्ट लाइक अ फीटल स्कैनिंग आल्सो।
Yes, please. So कार्डिक NICVD की हेल्प होगी, हम होंगे, एनेस्थेटिस्ट की टीम होगी, तो एक अच्छा कार्डियो ऑब्स्टेट्रिक क्लिनिक रन हो जाएगा और people will get more benefit, especially those women who have the congenital heart disease or who have other type of the heart disease. They have a good prognosis with collaboration of team. So cardio obstetric clinic is the need at Ladkana.
Comments. I would like to thank you to our all distinguished speakers, chairpersons for their invaluable contribution. We have had an enriching discussion on various aspects of the congenital heart disease in women with hormonal impacts to reproductive health and advanced imaging and genetic counseling, even which will be the need for the future as well. A special thanks to Pakistan Cardiac Society and American Heart Association for organizing this critical webinar and give us new access to conduct this. And my to all attendants, and thank you for joining us and for thoughtful engagement. We hope to see you in our future events as well. Stay safe and take care of yourself. Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you
It was
always.
really very interesting and nice interaction.
Thank you all to the speakers. Thank you to all the speakers and the panelists.
Thank you. Thank you.
Thank you, ma'am.